changes already happening in other courses in your new curriculum. We don't want to, our team doesn't want to add more. So we are not doing TBL. Now, what's the plan of next week? There will be one interactive session. Yes, everybody's happy with that. What is TBL? TBL is team-based learning. It's an excellent exercise, and I have worked on TBLs for years, and I like bringing TBLs in the courses. But I think new curriculum is not a good time to do that. So what our team has decided, I'll talk about team-based learning in spring. In spring 2026, absolutely, I will bring a team-based learning session. So that is why please pay attention. What is the plan for next week? There will be an interactive session by Dr. Charagundula on these two lectures, heme and iron. So please ask your questions there. And in supplemental, instead of TBL, there will be just a clinical case. So interactive will be about the lectures, questions, and the supplemental would be about clinical case. Now, what's my plan moving forward? Just so that it can be a help for you in the interactive session, I'm doing a quick recap. I have divided my recap into 2 sessions. Next week, I will not be doing either interactive or supplemental. What I'm doing, I will come after the session done by Dr. Charagundula in that week. So I have divided my recap into 2. Today, I'm going to do only heme metabolism. After Dr. Charagundula finishes all the lectures and session, in the next week after that, I will tell you the dates. I will do iron metabolism. And whiteboard. Anytime I will do one whiteboard, but you tell me the time, you all decide which would be the right time to do whiteboard. We actually just need one whiteboard for this. There's only one session in the exam. But you tell me the time, I will do whiteboard. So let's do GI. First of all, please, your review PowerPoint, topic list, and disease list, vitamin list, all are on the share now posted. So you can pre-prep. Very, very good exam to grab your grades. There are only 7 questions. First, work on heme metabolism, then go to iron. Always stick to your learning objective. Please first know normal to know abnormal. You can ask questions, but since it's a 50 minutes recap, I would encourage you to hold it at the end unless you're struggling with any concept. Does that work fine with you all? Yes? Everybody? Okay, so let's first do normal, then abnormal. So there's no TBL, please. Don't be confused. Interactive session for the lectures next week, and Friday would be clinical case, not TBL. Also, clinical case would be iron deficiency. Please know that. And both the sessions will be hosted by Dr. Charagundula. So let's move on. I like students being informed, organized, then they being lost, what's going on. So are you clear with that? So let's start this. I will explain you which steps are important and their clinical application. First, know normal to know abnormal. So are you aware of the rate limiting step in this pathway, which is synthase? What vitamin does it require? Anyone? Are you aware of the rate limiting step of this pathway? It's good to draw this outline, but please do only clinical or physiologically important step. So first step is rate limiting. Are you aware of that? And any vitamin that is essential for this step? Vitamin B6. Please bring your vitamins on the exams. Take your daily vitamins until your exam and bring them on your exam. Now, I want to address the clinical finding too. So yes, rate limiting enzyme, synthase, vitamin B6. Tell me, if you have a B6 deficiency, will you synthesize heme in your body? I will tell you every step and its clinical importance. So if you have no. What will that lead to? B6 deficiency will lead to microcytic hypochromic anemia or macrocytic anemia. What will B6 deficiency that's why lead to? Because there will be no heme. Yes, very good. Microcytic hypochromic anemia. Micro means small cells. Hypochromic means less hemoglobin. So you got to understand microcytic anemia for this exam. Please do that. Macrocytic, no, but I will differentiate macrocytic. That will come in spring 2026. So what is the importance of this step? B6 deficiency, microcytic anemia. Please do not forget. Secondly, do you know enzyme deficiency disorder? What happens to the substrate? Do they accumulate? What happens to the substrate? Are you following my pace? Are you following my pace? Yeah. What happens to the substrates? Yes, substrate accumulates. What happens to the products? Are they low? Are they low? Any enzyme deficiency step. Do substrate accumulate? Yes. Are products low? Yes. So what is the treatment? Either you supplement substrate or product in an enzyme deficiency step. Do you supplement substrate or product? No, I'm asking substrate or product. Enzyme is also replaced. You replace or you supplement product. You restrict substrate. You also supplement enzyme. But do you know that there is one more treatment, very, very important, of enzyme deficiency disorder is that you inhibit the rate limiting step. Now, who will tell me? Gene therapy is there, but who will tell me? So what do you do in enzyme deficiency step? For example, this enzyme, this step is deficient. You will replace, you will restrict HMB, you will supply Uro 3, you will supplement the enzyme, cofactor if any. But are you aware of this treatment that when you inhibit the rate limiting enzyme, how will this help? Tell me in an enzyme deficiency step. How will inhibiting the rate limiting enzyme help? What will that help in a patient's with any enzyme deficiency step? For example, it's here. Let me put my laser pointer. Tell me, if this step is defective, how inhibiting the rate limiting enzyme help? If you inhibit the rate limiting enzyme, how will this help? Anyone? Yes, not I would not say build up, but that's a very good answer. It will prevent the forward flow of the substrate. So please, build up is by the deficiency. Build up of the substrate, for example, this step is defective. Build up of the substrate is by the deficient step. But what will inhibiting ALA synthase do? It will prevent the forward flow of the substrate. So please, please, and please keep an eye on another treatment that help enzyme deficiency disorder is inhibiting ALA synthase. I'm giving you importance of each step and why they should be known. Second step, is it inhibited by lead? Absolutely. So tell me, if this step is inhibited by lead, what will happen to ALA in lead poisoning? Will it be high or low? What will happen to ALA in lead poisoning? High. So you got to know rate limiting step, intermediates around the step, physiologically and clinical step, intermediates around the step. If you didn't know that, now if I ask you, very good, lead poisoning, what will accumulate? ALA. But what about B6 deficiency? What will happen to ALA? High or low? B6 deficiency, low. So you understand how the accumulation is the most important because it's so high, it causes signs and symptoms. Sorry, am I freezing? Can you hear me? Can you hear me, everyone? Am I good?
No, apparently it was me who froze. You're fine.
Great. So see, unless you know the step, you will make that mistake. It's not in B6 deficiency, but it's in lead poisoning that ALA will accumulate or be high. In accumulate or will be low in lead poisoning. In lead poisoning, what will happen to ALA? High or low? Lead poisoning. High. So you got to understand the step. Next step is a defective in AIP. Now, this is the most common neurological porphyria. I will tell you later on why it's neurological, but now you got to know B6 deficiency, lead poisoning. Please start making the list. And AIP. ALA stands for delta amino levulinic acid, but ALA is also internationally accepted. Since you asked me, so I'm telling you that, right? Did I answer you? Delta amino levulinic acid, ALA. Okay? Did I answer you? Good? Yes. Okay. Okay, let's go further. Great. So this is the most common neurological porphyria. That's why you should know it. Now, this step, please know one thing. Cutaneous symptoms starts only and only when porphyrins accumulate. Until then, cutaneous symptoms will not start. So that is why look at this step, which is AIP. Do you see porphyrins accumulating in AIP? Do you see my cursor? Do you see porphyrins accumulating in AIP? Do you see my cursor? Will you see porphyrins accumulating in this step defect? Yes or no? No, that's why AIP is purely neurological. You got to differentiate neurological and cutaneous porphyria. You got to understand that only when porphyrin accumulates, you have cutaneous symptoms. Otherwise, a big no. But look at this enzyme deficiency. Will you see porphyrin accumulating in them? Look at this step defect. Will you see porphyrin accumulating in them? Whether it's Euro 1, Euro 3. I'm not asking that. In this enzyme deficiency, will you see porphyrin accumulating? Why not? Yes. Is Euro 1 accumulating? Yes. That's why the next porphyria is both neurological and cutaneous. Neurological symptoms are because of ALA and PBG. Cutaneous symptoms are anywhere porphyrins accumulate. So do you agree that CEP will be both neurological and cutaneous? Yes or no? Yes, understand that. Now, what's the last porphyria you should also know, which is purely cutaneous, is PCT. Now, in PCT, what is accumulating? Tell me. What is accumulating in PCT? What is accumulating in PCT? Euro 3. That's why it's a porphyrin. It's a purely cutaneous porphyria. Absolutely. So understand B6 deficiency, microcytic anemia, rate limiting enzyme, treatment, inhibition, treatment of enzyme deficiency disorder. Lead poisoning, ALA accumulates. Purely neurological, no porphyrin accumulation. AIP. CEP, both neurological and cutaneous because porphyrins accumulate. PCT, purely cutaneous. Porphyrins accumulate. Rest, though they are important for boards, oxidase, but please first do AIP, first do B6 deficiency, rate limiting enzyme, lead poisoning, AIP, and PCT. Then you move on to the other porphyrias. Last step, is it inhibited by lead-2? Is last step inhibited by lead-2? Is the last step. So now tell me, since you know, so which steps are inhibited by lead? Look at my laser pointer, second and the last. So tell me what would be high in patients with lead poisoning. If the second step is inhibited by lead and last, so you can't flip-flop the steps, okay? So tell me what will happen in patients with lead poisoning. If second and the last step is inhibited, what would be high? Tell me what would be high in patient of lead poisoning, since high ALA, very good. And secondly, high zinc porphyrin. Why zinc porphyrin? Because if this step is inhibited, will iron be incorporated to form heme? If the last step is inhibited, will iron be incorporated to form heme? Yes or no? No. That's why what gets incorporated in porphyrin? Now zinc instead of iron. That's why two things rise big time in lead poisoning: ALA and zinc porphyrin. I have addressed that in my slides. But definitely there are more to it. So are you aware of these steps? Any confusion? Allosynthetase, B6, yes. Lead poisoning, second and last, yes. AIP, pure neurological, yes. PCT, pure cutaneous, less, yes. What is CEP then? What is CEP then? Neurological, cutaneous, or both? Both. And whenever there is cutaneous, what should accumulate? Porphyrins. If there are no porphyrin accumulation, it cannot be cutaneous. Let's move forward. This is the big summary. So let's see what steps I told you. I like repeating stuff so they stick and you know the focus. Rate limiting, B6. Tell me two. Which poisoning? Two-step. Which poisoning? Yes, you can unmute and answer too. And please don't be discouraged with some people answering and some not. You have a lot of time. Here we are just learning and you compete with yourself. Very good. Two, lead poisoning. What is three, porphyria? AIP, PCT, or CEP? Two-step porphyria. AIP, CEP, or PCT? Two-step. Sorry. Three-step. Sorry. One is B6, rate limiting. Two is lead poisoning. Three-step defect is what? Three-step defect is AIP. Absolutely correct. Purely neurological. What is fifth? What is fifth? Which is purely cutaneous. Purely cutaneous. Fifth. PCT. Absolutely right. And in the middle, fourth one is CEP. What about eight? Step eight. Step 8 is inhibited by step 8, last step, lead poisoning. So this is the summary. What you got to know is, yes, step 1, absolutely. 2, 3, 4, 5, and last 8. Okay? Focus on your test. There are only 7 questions. So let's look at the difference between AIP and PCT, which you should know very well. So tell me, is this AIP? Is this step that I have said defective? Is it AIP? In this slide, is this step AIP? Is this step defect AIP? Which is 1, 2, and 3? Yes or no? Is this AIP? Absolutely. Now look at this. What is accumulating in this step? ALA and PBG. Are there porphyrins accumulating in this step? No, that's why it's a purely neurological porphyria. Go and look at my videos why LI and PBG are neurological. They are not cutaneous. They don't lead to cutaneous symptoms. They lead to abdominal pain and neuropsychiatric symptoms. That's why purely neurological AIP. Let's go to concentrate more on what is accumulating, right? Any question? Okay. What is PCT? Is PCT this step? Next slide. Is PCT this step? Yes. Is PCT purely cutaneous? AIP. So what accumulates in PCT? Please mute yourself. Yes. So is it purely cutaneous porphyria? Because LI and PBG are left behind. They are not accumulating much. What is accumulating is porphyrins, purely cutaneous. So do you have any confusion between purely neurological and purely cutaneous porphyria? Purely neurological AIP, you will not see porphyrins there. You will not see cutaneous symptoms there. Purely cutaneous PCT, you will not see neurological symptoms there. And what are the cutaneous symptoms due to porphyrin? What are cutaneous symptoms actually? Skin blistering, disfigurement, the werewolf's appearance. No worries. So this is AIP and PCT. Concentrate on what is accumulating. Then treatment. How will you treat neurological? Treat the abdominal pain, neuropsychiatric symptoms. Cutaneous, treat the cutaneous symptoms. AIP, you will concentrate on which symptoms? Neurological or cutaneous AIP? Yes, so purely neurological means no porphyrins, absolutely. AIP is neurological, so you will treat neurological symptoms. And PCT is purely cutaneous, you will see cutaneous symptoms. Now, what is this glucose loading and heme and hemin? Why do you want to inhibit ALA synthase? Why do you want to inhibit ALA synthase in porphyrias? Is it one of the treatment to inhibit ALA synthase? Do you want to inhibit synthase, the rate limiting enzyme in these porphyrias? Yes, that can be done by feedback inhibition. Actually, they are given heme, hemin, or glucose. They all inhibit synthase. Why you don't want the forward flow? So treatment is important. Why not? But which is a blanket treatment for all porphyrias? Yes, neurological, you will treat neurological symptoms. Cutaneous, you will treat cutaneous symptoms. But what's the blanket treatment for all porphyrias? Irrespective, neurological and cutaneous. What do you want to inhibit? Which enzyme? Which enzyme you want to inhibit in all porphyrias? Tell me. Which enzyme you want to inhibit? Synthase, the rate limiting enzyme. Please try to distinguish that. It's not about first order questions now with the new curriculum. It's about thinking and second, third order question. Why I want to inhibit synthase in neurological as well as cutaneous porphyria. Do that for me, okay? We will have chance to open question, but now I want you to go towards microcytic versus macrocytic anemia. All microcytic anemias are addressed in this lecture, but they are on the base of factoliter. The MCV, which is known as mean corpuscular volume, is synthetase. When you say someone has a good question, it is synthetase because any synthesis that requires ATP is labeled as synthetase, not synthase. So it's synthetase, but it's used either ways in text. Synthetase is the term used for the enzyme when synthesis require ATP. This step also needs ATP, so it's synthetase. Okay, did I answer you, please? Synthetase is used when the enzyme requires ATP. Okay, great. So MCV decides it's micro versus macrocytic anemia. If more than 100 factoliter MCV, that's the cutout point for macrocytic, which we are not doing in this fall. We will do in spring. What we are doing is microcytic anemia. Please be mindful of all the causes of microcytic anemia. I've enumerated them, but history is very important too. So tell me, first of all, which is the most common cause of microcytic anemia? Which is the most common cause of microcytic anemia? Does anyone know that? Most common cause of not B6, not B6, not lead poisoning. Not everybody is having iron deficiency. Very good. Iron deficiency is the most common cause of microcytic anemia. Lead poisoning you will see in paint, glaze, potteries, batteries. Initially, lead was not monitored in the house paints. And initially, there was history of infants chipping that paint and licking that paint from the walls. It's not seen now because lead levels are monitored for there's a reference for the wall paints, but yes, absolutely. Good input. But that's where I'm going. So iron deficiency, iron loss, lead poisoning, paint, glaze, batteries, potteries, workplace, or history, not with infants anymore, that they lick their wall paint, but uh, glaze, paints, potteries, and batteries, anything to do with pain, lead poisoning. B6, any anti-tubercle drug which is associated with B6 deficiency, very commonly asked on boards. Any anti-tubercular drug which is associated with B6 isoniazid. Keep an eye on history. Vitamin C, you know, when you are not taking citrus fruits, bleeding gum, falling out of teeth. I will also tell you why vitamin C leads to microcytic anemia. But are you aware of iron? We will do in the next session. Are you aware of B6 and deficiency and lead poisoning leading to microcytic anemia? Are you aware of B6 deficiency and lead poisoning leading to iron deficiency anemia? Oh, great. Please know that. I will add vitamin C, also important. Copper, I will add in the next session, which will be, I'll inform you when it is. So, are you aware of microcytic anemia, iron, B6, and lead poisoning? History I have given here. I just want to bring attention to one thing which students always ask. What is sideroblast? Sideroblasts are formed when iron is deposited outside as a ring around the RBCs. Then iron is deposited as a ring. And ring sideroblast you will never see in, tell me, iron deficiency, B6 or lead poisoning, where you will not see iron around as ringed sideroblast. Iron deficiency, B6 or lead poisoning, sideroblastic anemia or sideroblast, not lead poisoning. In lead poisoning also iron is not used, so can accumulate. Iron deficiency because there is no iron. So how will it accumulate, right? So iron deficiency, you don't see ring sideroblasts. And sideroblastic anemia is sometimes a clinical presentation addressed with both B6 deficiency and lead poisoning. So that is your focus about heme synthesis. Let's look at heme catabolism. Very simple. Please don't go overboard with it and join chat GPT. Just come to me. I'm your chat GPT for biochemistry and genetics. First, know that prehepatic, hepatic, and posthepatic jaundice, there are only three, please, phases, normal. In prehepatic jaundice, you form bilirubin. Tell me which bilirubin you form in prehepatic jaundice, conjugated or unconjugated? Tell me. Which bilirubin you form? Look at my cursor in prehepatic jaundice. Conjugated or unconjugated? Conjugated or unconjugated? Not conjugated, please, because conjugation is happening in the liver. Absolutely. First, no normal. What there are three phases of heme catabolism: prehepatic, hepatic, and posthepatic. Prehepatic means before the hepatic system. Posthepatic means after the hepatic system. So prehepatic system, normal hemolysis when RBCs complete the lifespan of, what's the lifespan of RBC? I hope just to wake you up. What's the lifespan of RBC? 120 days. Then you will have bilirubin in serum. Please know there is a difference. Bilirubin in serum is different from bilirubin in urine. Don't get confused, I will tell you. So yes, in the prehepatic phase, normally you would get common causes of macrocytic anemia is what? Common causes of macrocytic anemia are B12 and folic acid deficiency, which will be taught to you in spring 2026. Wow, we are already in 2026. Yes. So macrocytic is not for fall 2025. Great, he's happy. Anyways, so prehepatic gives you bilirubin, which is unconjugated. Does this bilirubin ever show up in urine? Does this bilirubin ever show up in urine? This bilirubin here, right here. Does it show up in urine? Yes or no? Unconjugated. No, 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 and never. Unconjugated bilirubin never shows up in urine. So let's finish prehepatic jaundice. So this is normal. Physiologically, 120 days, RBC hemolysis, bilirubin formed. But now look at prehepatic jaundice. If there is excess abnormal hemolysis, what will increase in serum? Which fraction of bilirubin will be predominantly high in the serum if there is excessive abnormal hemolysis? Maybe hemolytic anemia, sickle cell, any hemolytic anemia. What will be, isn't we are not talking about urine, please. I'm here in serum. Let's talk about circulation. I will come to urine too. There's a difference in bilirubin in urine versus bilirubin in serum. I'm talking about bilirubin in serum right now. Let's focus, okay? So tell me, if you have an excessive abnormal hemolysis, what will happen to unconjugated bilirubin in the serum? Will it be predominantly high? Yes or no? Will this fraction increase in the serum? Yes. Will this fraction ever show up in urine? No. So there are three parameters done to detect jaundice. Number one, you observe bilirubin in serum. Number two, you observe bilirubin in urine. They are not the same. Please don't they make that mistake. Lastly, you observe bile pigments in urine as well as feces. Bile pigments is not same as bilirubin. Please don't make that mistake. Bile pigments, name the bile pigments. They are not bilirubin, they are bilirubin derivatives. Name the bile pigments. Name the bile pigments. Name the bile pigments. They are not bilirubin. Anyone? Urobilin and stercobilin, they are bile pigments. So three parameters you do. You assess serum bilirubin, you assess urine bilirubin, and you assess bile pigments. Bile pigments are urobilin in feces, urobilin in urine, and stercobilin in feces. Don't flip-flop these parameters. So first of all, in prehepatic jaundice, tell me what will happen to unconjugated bilirubin in serum. High or low? Unconjugated bilirubin in the serum, very high, predominantly high. Will that show up in urine? Will this bilirubin high show up in urine? No. So in prehepatic jaundice, urine bilirubin will be nil or absent. Now look at the bile pigments and urine and feces. Since there is nothing wrong with the hepatic and post-hepatic system, tell me, in prehepatic jaundice, what will happen to urobilin in urine and stercobilin in feces? Will they be high or low? What will happen to urobilin in urine and stercobilin in feces in prehepatic jaundice? Will they be very high or low? Because this tap is very high, because this tap is on. Everything is going down and increasing urobilin and stercobilin in feces. So are you clear with the prehepatic phase and prehepatic jaundice? Right? Let's move to the next phase, which is hepatic. What's happening in the next phase? Conjugation. What do you need for conjugation? UDP carrier and glucuronide transferase enzyme. But tell me, is this conjugated bilirubin, can this show up in urine? Can this conjugated bilirubin show up in urine? Yes, please know that, not this one. This is unconjugated, this one is conjugated. This is the second phase of heme catabolism. Last phase, let me complete the last phase of heme catabolism. There is first deconjugation and then formation of uro for urine and sterco for feces. So this is normal metabolism. I did prehepatic jaundice. Let's do posthepatic jaundice. So tell me, what's the cause of posthepatic jaundice? Cause of prehepatic jaundice is excessive abnormal hemolysis. What's the cause of posthepatic jaundice? Posthepatic cause. There is obstruction to common bile duct by stricture, stone, stricture after surgery, stone, and carcinoma head of pancreas. So tell me, in post-hepatic jaundice, what kind of bilirubin will build up in the liver? In post-hepatic jaundice, what kind of bilirubin? Conjugated bilirubin. Will that show up and spill back in circulation and show up in urine? Will that bilirubin spill back into the circulation and show up in urine? Yes. So let's see what happens in post-hepatic jaundice. Which fraction of bilirubin will rise in the circulation because of backup? Conjugated or unconjugated? Which bilirubin will rise big time because of backup? When there's a post-hepatic obstruction, conjugated bilirubin will be very, very high. Will this bilirubin show up in urine? Yes. Yes. And what will happen to bile pigments? If the obstruction is complete, you will see clay-colored stools. No, what will happen? There's an obstruction. Bile pigments cannot be high, please. You got to understand normal to understand abnormal. If there is an obstruction to common bile duct, bile pigments cannot be high in either urine or feces. That's why what do you see in post-hepatic obstruction? Due to complete obstruction sometimes, clay-colored stools. So we finished pre-hepatic, we finished post-hepatic. For hepatic, please, you will be taught in second year too. I will only address the most common cause of hepatic jaundice. Bilirubin, which is bound to albumin, is unconjugated. Yes, it is unconjugated. It is unconjugated if somebody is asking question. Now let's look at hepatic jaundice. Hepatic jaundice most common cause is either toxin, alcohol, viral, any injury. So tell me, will liver in hepatic jaundice lose the capacity to conjugate? In any cause of hepatic jaundice, will liver cells lose the capacity to conjugate bilirubin? Yes, that's why there is no predominant rise. Here in the serum, you will see a rise in unconjugated over conjugated bilirubin. Since there is a rise in fraction and also, but still unconjugated bilirubin in rising, it will never show up in urine. And in hepatic jaundice, this enterohepatic circulation is increased. So in hepatic jaundice, you don't see clay-colored stool. You will see urobilin and stercobilin in urine and feces respectively. Does that answer does that distinguish three type of jaundice? But also, I will address your questions when I come back. So, prehepatic phase, you form bilirubin. This is unconjugated, never shows up in urine. That's why prehepatic jaundice, bilirubin is nil or absent. Hepatic jaundice, conjugation, oh sorry, hepatic phase, conjugation happens here. That's why hepatic jaundice, unconjugated fraction rise over conjugated. Post-hepatic phase, bile pigments are formed here. That's why post-hepatic jaundice, you can see clay-colored stools. Please just distinguish prehepatic, hepatic from post-hepatic, and also know that it's only the conjugated bilirubin that shows up always. There are only three parameters you do: bilirubin in serum, bilirubin in urine, and bile pigment in urine as well as feces. Please do not flip-flop them. They are not the same. I have enumerated prehepatic, hepatic versus post-hepatic jaundice, but for diagnosis, don't forget the enzymes. Students tend to forget. We have learned this. Have you learned high ALT and AST as a marker of hepatic damage? Have you learned high ALT and AST as a marker of hepatic damage? Have you learned that? Yes or no? Yes, but don't forget this enzyme ALP. That's a marker of bile duct obstruction. It's a duct enzyme and is high in obstructive jaundice. Please distinguish these two enzymes. ALP is known as alkaline phosphatase, also a duct enzyme, high in obstructive jaundice. I have done treatment of porphyria. One which is very important is in premature babies. So premature babies, are their liver mature? When babies are born premature, are their liver mature? Are their liver mature? No. So they do not have a capacity to conjugate. So what type of bilirubin rises in premature infants or in case of excessive abnormal hemolysis? Excessive abnormal hemolysis or premature infants? What kind? Unconjugated. And remember, does unconjugated show up in urine? Does unconjugated show up in urine? No, it is not water soluble. So that is why the treatment is blue light, please, not UV light, to convert unconjugated bilirubin into a water soluble isomer and get rid of this from an infant's or newborn's body. So blue light is essential for forming water soluble isomer. right? Because unconjugated is not water soluble. Now, next time I will do iron, please do this for me for iron when I come back. What is the role of iron? What is the regulation, enzyme deficiency, as well as toxicity? I just want to talk about this last slide, which is very important for iron. Please do this when you come to me next time. Is this normal iron regulation? I will quickly explain you that you need to understand that this is lumen, this is cell, this is circulation. There are different transporter. Look at this transporter moving non-heme ion, this transporter moving heme ion, but ion should be always for absorption. What state? What state it's only absorbed? Fe plus 2 or Fe plus 3? What state? Fe plus 2. And look at this. Which is the reducing agent here? Who is helping iron absorption? Which is the vitamin C. So in vitamin C deficiency, will you see iron deficiency anemia? Will you see iron deficiency anemia? Because vitamin C is very essential for iron absorption. So please know microcytic anemia is because of B6 deficiency, first iron deficiency, B6 lead poisoning, and also vitamin C deficiency. But look at this. Once iron is absorbed in the Fe plus 2, it has to be in Fe plus 3 to store as ferritin and transported as transferrin. Fe plus 2 is only and only for absorption. Fe plus 3 is for storage and transport. Who who forms Fe plus 2? Vitamin C. Who forms Fe plus 3? Who's responsible for Fe plus 3 formation? Two protein, hephaestin and ceruloplasmin. Now, lastly, what is ferroportin doing? Moving iron from lumen to circulation. And who is the negative regulator of ferroportin? Hepcidin. So now tell me, this is my last question. You know all function, right? This transporter moving Fe plus 2 in non-heme. This transporter moving heme ion. Vitamin C essential for iron absorption. Vitamin C deficiency, microcytic anemia. Once Fe plus 2 is in the intestinal mucosal cell, for storage, Fe plus 3 for Fe plus 3 form. For transport, Fe plus 3 form. Who forms Fe plus 3 form? Hephaestin, membrane bound, ceruloplasmin, circulation. What is ferroportin doing? Pushing Fe plus 2 from cell to circulation. What's hepcidin? It's a negative regulator of ferroportin. Please know everything before you come to my next session. But now tell me the last question. If you are low in iron, will liver increase hepcidin or decrease hepcidin? If you are low in iron in your body, iron stores in your body, if your body senses that you're low in iron stores, will liver increase hepcidin release or decrease hepcidin release? Decrease hepcidin release, because you know hepcidin is a negative modifier for ferroportin. Good luck. I will tell you when you will have your next session now, because next session would be iron metabolism. Great. I wish you all good luck.
Thank you, Dr. Beck.
Good luck.
Thank you so much, Dr. Bach.
You're welcome.